Hello, everyone, and welcome to today's session, How to Bill for Remote Patient Monitoring Services Like a Pro. My name is Ryan Carrico, Senior Marketing Manager here at Gluco, and we are excited to have you all join us for today's webinar, the second in our four-part series for Diabetes Connected Care. Presenter, Marianne Hodorowicz. Besides being a licensed registered dietitian, nutritionist, and a certified diabetes educator, Marianne is also a certified endocrinology coder and earned her MBA with a concentration in marketing. She is a nationally recognized expert in many areas of diabetes care, and especially in Medicare, managed care, and commercial payer reimbursement. In this capacity, she has worked with hundreds of healthcare professionals and entities, professional membership associations, and government agencies across the country. We're thrilled to have Marianne join us today to share her wealth of knowledge on remote patient monitoring. Now, without further ado, I'll pass it to Marianne.
Hello, everybody. I am so pleased to be with you. Objectives. I'm not going to read all these for the sake of time. One other thing I do, some of you are familiar with me, I will say sometimes pens up, and that means, what is she meaning, pens up? It means that what I'm going to say is not in the slide deck, and so you may want to jot it down on paper or make a note of it in your notes app on your cell phone. It's so important, it is in the slide deck, but it's so critically important that writing it down or putting it in your phone would be good. And again, this deck is going to be available to you after today's webinar, along with 4 different handouts that I created, 2 different types of progress notes for remote monitoring. And when I designed the 2 different formats, I tried to make those progress notes compliant to the Medicare qualifications, rules, coverage guidelines, and they're all modifiable. They're on Microsoft Word, so just do whatever you want with them. You can take my name off. And then I designed a remote monitoring consent form, because Medicare beneficiaries, one of the rules is from Medicare that they have to sign a consent form, and that has to be uploaded into the patient's EMR. So this is focusing on the Medicare rules for remote patient monitoring, and I'm just going to say RPM. This is all about Medicare. With Medicare, you either love them or hate them. I love them because maybe not Medicare for all, but or maybe so, who knows, but they have wonderful benefits, but their coverage guidelines tend to be all about the C's: complex, convoluted, challenging, copious, and sometimes, I'm going to say it, kind of crazy. And like, what are they thinking? What are they doing over there when they make up some of these rules? But, they service a lot of beneficiaries. So today we're going to call her beneficiary. That's the term for the patient in Medicare, is we're going to call her Martha, as in Martha Stewart. You know, love this woman or hate that woman, either way, right? Okay, RPM services, what are they? They include establishing, implementing, revising, and monitoring a patient's treatment plan. Now, I'm not going to read word for word from each slide. I won't do that, but I'm going to highlight what's really important on each slide. The important thing here is, of course, remote, and we have to use an FDA-defined digital device. We'll talk about that later. And it's all about the patient's physiological data being collected by Martha and wirelessly transmitted by Martha, collected and transmitted wirelessly to Dr. Miller. And just going to say Dr. Miller, who's going to be our provider. So we have 4 different RPM codes now, and one of them, the first one we're going to review, is actually can be done live in person, and that is the training and setup, but we'll talk about that. So this is all outside of an in-office visit, which is wonderful for convenience. Now again, CMS, that stands for the Centers for Medicare and Medicaid Services, and that's the governing body over Medicare. It stands for the Centers for Medicare and Medicaid Services. That also includes Medicaid. Okay, so a lot of people say to me, well, gee, Marianne, our private insurances, commercial private like United, the Blues, and state Medicaid programs, are they covering this, and are the guidelines the same, the reimbursement guidelines? And the answer is, I don't know. Commercial payers do not have to follow Medicare guidelines. They can do whatever they want. The same with Medicaid programs, and there's 50 of them in the country. But the Medicaid programs still look to CMS as their governing body when they format what benefits they're going to pay for and their coverage rules. Okay, so CMS does make a distinction with Medicare now between active technologies and passive. The passive platforms and devices, they don't virtually transmit the data in real time. And so those kind of platforms cannot be used. So it's all about wirelessly and virtually transmitting what they call patient-generated health data in order for Dr. Miller and his clinical staff, RNs, RDs, pharmacists, even medical assistants, the people who work for him clinically or even in a hospital outpatient department, and we'll look at those places of service. We're using that patient-generated health data to do Martha's assessments, her ongoing monitoring of her data, and then Dr. Miller or Mary Ann, the RD, or Barbara, the RN, can then call Martha on the phone or text or email her once we look at her data coming into our platform in our office. We're looking at her blood glucose data, for example, and Mary Ann's looking at it as the RD, or Dr. Miller's looking at it, or Barbara, the RN, and we call Martha on the phone and say, you know, Martha, we're seeing that your blood sugar is peaking way too high after you eat, and so we're going to change this in your meal plan, or we're going to change this medication, or change this insulin. And that's what we mean by that one-way care plan guidance: telephone, email, and text. But of course, we have to get the patient's, Martha's, permission to do that on a consent form. And you were able to receive the consent form that I developed from different references I used online. So let's jump right into the codes now, the CPT procedure codes. I'm just going to say procedure codes. And the first one is 99453. Now, these codes are paid under Medicare Part B, which is where all the outpatient benefits are housed. Medicare Part A houses all of the inpatient benefits and some others, and Medicare Part B is really outpatient. So we've got the first code, 99453, and basically what that is, it's the supplying the patient with the device. It's called device supply. It's giving Martha the blood glucose meter that specialized meter that has the ability to wirelessly transmit her blood glucose data from her meter right to Dr. Miller's office. Or you give her a Holter monitor. Like just a month ago, all transparency, I had to wear a Holter monitor for 24 hours. So that's considered a medical device that they've loaned me for 24 hours, and I had to return it. Okay, so with this particular code, if you think about it, in order to bill this code, the device that you loan to Martha or you give to Martha to use during the remote monitoring period, you basically have to own that device. You have to have paid for it, because the essence of reimbursement, the core concept of reimbursement, is that you're billing Medicare to get money back. You've incurred an expense, and you're billing Medicare to get your money back. And so if you got a whole case of free blood glucose meters, you didn't pay for them, and they're the specialized meters that allow that wireless transmission, but you got them free. And then you give one to Martha. Technically, you cannot bill for this code because you incurred no expense. But if you did purchase it and you give it to her or loan it to her, either way, because you've incurred the expense, you can bill this code. And it says each 30 days. So that means if Martha has it all the month of April and May, for the month of April and the month of May, one time in April and one time in May, you can bill this code. But look at the bottom right. These are, again, Medicare rules. You can only bill this code if Martha has been doing the monitoring for 16 or more days in that calendar month, for 16 or more days in that calendar month. So that's why tracking minutes, you'll see that in some codes where we're tracking minutes, But tracking these days in your progress note or your EMR template is going to be important, so you're billing legitimately and accurately, okay? So again, the device itself has to be defined as a medical device, defined by the FDA. And these words they all mean something. Each word means something. A medical device defined by the FDA, okay? And we talked about that wireless transmission. Now, what is the date of service on the claim to bill this device supply code? It's the date in which the device is given or delivered to the patient or caregiver. But because the patient has to do the monitoring for 16 days or more, okay, I would, in my opinion, I would wait for that 16th or 17th day before I actually build this code. Now, at the bottom, you can see that CMS is still to give us guidance on what type of technologies can be used for the device kind of thing. They were not really granular with their first publication of these first initial reimbursement rules, and that's unfortunate because there's been hundreds and hundreds of comments and questions that have gone into CMS about what devices are used, like, Fitbits and watches and that kind of thing that record physiological data. This is not just for blood glucose. This is for any kind of physiological data. So we'll talk more about that in a minute. So this is a practice expense only code, and that means physician work is not required. You're supplying the device to Martha. But again, you have to own it, and you're loaning it out or giving it, and you've incurred an expense. That's really important. So that's what this slide speaks to. If you've gotten these devices free, like when I wore the Holter monitor, obviously I don't think my hospital got that free. They had to pay for that Holter monitor, and I had to return it. And that's why they were able to bill. Okay. Now, when we talk about the type of technology required for that particular code, it says FDA defined. That's how Medicare, the language they've used. And they said they'll give us further guidance. But we do have some guidance already. Okay. So software applications that can be integrated into Martha's smartphone, the answer is yes. Those are now considered a medical device by the FDA. I have another slide on that coming up. But like Holter monitors are, we know that. Fitbits, we're not so sure about that. And like the Apple Watch, I'm not trying to be brand specific, and I'm not being paid by any company to mention a brand name. But we have to be careful because we don't have a lot of precise guidance from CMS at this point, okay? But CMS did say that they're going to issue guidance in the near future to help people with this benefit. So the best way to keep up to date, ladies and gentlemen, about that future guidance when Medicare speaks, is to sign up for what's called the CMS Medicare Learning Network. And you see it here. I just clipped it out of the CMS website. And you see the URL, the link down at the bottom. Anyone can sign up for this MLN newsletter, and you get it into any inbox email that you give them, and you don't have to be a Medicare provider. My son, who's a restaurant manager, could sign up for this. And that's how I keep updated for the work I do on the changes that Medicare makes to any of their benefits, okay? And you'll get it into your inbox. So it's a really good thing to do. So I'm going to go through these examples, and then I'm going to ask Ryan if there's been any questions inputted into the chat box when we go through these examples on the equipment. So on this equipment, the device supply, hardware devices such as cellular-enabled blood glucose meters, this would count. This would count because those apps, the meter has this ability to transfer that data wirelessly, and it is an FDA defined medical device. And so another example is these applications or apps that we install on smartphones. And oh gosh, we have a lot of those to transmit a lot of different types of physiological data, not just blood glucose, which we're used to, but even virtual body weights and virtual blood pressure. All of those kind of apps exist for different types of Martha's physiological data. So these apps now that transmit medical data for the care and assessing and monitoring and treatment planning based on medical data. Those apps are now FDA defined as a medical device. And this is where I dropped in this information per the FDA. You could see at the bottom, apps can be considered medical devices if they are intended for use in the diagnosis of the cure, mitigation, treatment, or prevention of the disease, or to affect the structure or any function of the body. So that's really good. That's really, 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 really good on these apps. And the same thing for software. So maybe Martha doesn't have the smartphone, she's 79 years old, but she has a tablet and she has software where she's collecting the data, pushes a button, and the tablet transmits her blood glucose data to Dr. Miller. That software is also considered then, if it's medically orientated, it's a medical device defined by the FDA. So that's really, really good. And that's what this example shows. It's the software, again, related to medical decision making for diagnosis, cure, and treatment of medical illnesses. So if you go to I gave you the URL here at the bottom for the FDA references on software and apps. So I hope that's helpful to you. Okay, I'm going to skip that one. Actually, I'm going to cover these codes, and then we'll open it up to questions. Okay, the next code, 99454. This is for the initial setup and the patient education and the use of the equipment. So you sit down with Martha, and this is typically done face-to-face. This is typically not done remotely. This is the one that's usually done face-to-face, where you sit down with Martha in Dr. Miller's office or in the hospital outpatient department and show her how to use the blood glucose meter or the Holter monitor. And that's exactly what happened to me when I had the monitor on. They sat down in the hospital outpatient department and put it on me and taught me how to use it and clipped the little monitor receiver, and it was all good. But here again, physician work is not required. Clinical staff can do this. But again, you can see on the right that the patient has to do the remote monitoring for greater than 16 days in the month in order to bill for this. Now, the frequency, we can only bill for this code one time. We can only do that initial training and education one time. The device supply, the 99453, where we supplied her with the meter that you paid for, we can bill that every 30 days, once every 30 days, as long as she's remotely monitoring and using the device. On the education and setup and training, that can only be done one time per patient. But Martha has to be monitoring for at least 16 days in that calendar month. The third of the four codes is 99457, and this is the actual monitoring by Dr. Miller and his clinical staff of Martha's data, and I'm just going to say blood glucose data because I'm in the diabetes world, but again, it could be blood pressure, it could be her body weight, it could be all sorts of physiological data. And I'm sure there's people on this call that monitor other physiological information. So this is Dr. Miller and the RN and the RD and the pharmacist are in the office, outpatient department, and we're looking at her data on software that's been loaded into our computers by the medical device company or manufacturer, or the software data management review software has been integrated into our EMR. And we're looking at it as it's coming in, and we call Martha on the phone and say, change this, do that, I have a question, or we text her or we email her. Again, those three ways to communicate, telephone, email, and text, we would have to get her permission for any or all of those communication methods on that consent form, which we have to do anyway to start this benefit. So in the course of the month, this is a month now, and this is really good that they defined it as a month. Once you reach that 20-minute threshold, then you can bill this code. So maybe you spent 1 minute on April 14th and 2 minutes on April 20th and another minute on April 28th. So April 28th, you've got your 20 minutes. Then you can bill this code. You don't have to wait until April 30th. So it is one time on frequency per each calendar month. So you had 20 minutes or more threshold in April. You still have her doing the monitoring in May, and you get another 20 minutes in May. So it's one time per each calendar month when you meet that 20-minute threshold. Now, if Martha is already on CGM, you start her on remote monitoring for these functions, what we're talking about, this modality, this benefit. But in addition, you have her on CGM, and you want to bill with CGM codes 95249, 50, and 51. You cannot bill both at the same time for Martha because they're both remote or virtual monitoring of physiological data. They're very, very similar. And so Medicare, in their initial first round of reimbursement guidelines, said they actually stated in this first round of guidelines for remote monitoring that billing both remote monitoring and CGM at the same time for the same patient is not allowed. And we don't want to bill also the remote monitoring, this code 99457, with the chronic care management codes. Same patient, same period of time, like the month of April, because chronic care management is a separate benefit within Medicare that is about virtual care. It is virtual care. The guidelines are different. In chronic care management, the beneficiary has to have 2 or more chronic diseases that are going to get worse over time or could lead to death or severe morbidity. So there are different rules, but we can't bill CGM or chronic care management codes at the same time for the same patient with 99457. So because we have to meet that 20-minute threshold for 99457, that's why I designed these progress notes, RPM progress notes, and they're 2 different formats to kind of give you an idea of how to be tracking those minutes as you go through the month, and then what type of activities, like talking to Martha on the phone, what type of activities really fall under remote monitoring. So I did a lot of research and benchmarking. There's not a lot out there for forms and templates. I did the best I can. I'm not saying they're the cat's meow, but maybe it'll help jumpstart so you can bill for this like a pro, like we talked about in our title. Now, on these 3 codes, you can see here on the right-hand side that Martha does have a 20% copay, and that's 20% of the geographically adjusted reimbursement rate that Medicare is going to pay you. It's not the national rate. When you look up the rates, you can see the national rates and the geographically adjusted. And you're always going to be paid geographically adjusted. And she's responsible for 20%. And the deductible is going to be applied also to these codes. Okay. Now, what's really funny about this, and then I'm going to open it up for questions, is that you do not need to bill the setup and training code 99454. You don't need to bill that one to bill the 20 minutes of monitoring. Say that the patient already had the device. They already had the FDA-defined device to do the monitoring. They got that from, a year ago, and they still have it. So you don't have to do the setup and training, but you start to do the 20 minutes of monitoring. Then you can bill the 99457. And then at the bottom, it's the reverse. If you do the training and education for 99454, but then she doesn't do any monitoring, then there is no 99457 20 minutes to bill. But if you did that hookup and training and education, you can bill that 99454, even though she did not go on to do any monitoring. So again, this is the Medicare rules that we have gotten so far. Okay. Because when Medicare comes up with new benefits and they roll out their first initial reimbursement rules or guidelines, they're always not complete. And a lot of them, too, are what I call fuzzy-wuzzy. You have to interpret what they're saying. They're not really clear. So the incomplete rules, the fuzzy-wuzziness of the rules, and early on, there was a lot of negativity, negative comments going to CMS. We need more guidance. And this thing about direct supervision and general supervision, you can see here effective in 2020. When the initial rollout of these codes came in 2019, it said that these codes had to be furnished under direct supervision. They have changed that because of all the complaints that have gone into CMS Medicare from practitioners just like you. So the bottom line is, pens up, you can change the mind of Medicare by submitting enough concerns, complaints directly by calling your MAC or emailing Medicare. They have an email address on the CMS site, cms.gov. You can change the mind of Medicare. This is a clear example. So they changed it from direct supervision to general supervision. And that means that Dr. Miller does not have to be in the same building at all when his clinical staff are furnishing any of these codes. He doesn't have to be there. He could be making his rounds at the hospital. He could be on the golf course. He could be at home because he's sick. As long as he's in communication electronically through a phone or pager, you're good. So this is really, really excellent. Okay, that's one of the best changes they have ever made. I get goosebumps when I think about that change because it really opens up this benefit to be used comprehensively and holistically in real, honest-to-goodness practice settings with real patients in real time. Okay, the fourth code we have, which is new in 2020, this is exciting. I got goosebumps about this one, 99458. This is a new one that's been added, and this is for an additional 20 minutes. We had the first 20 minutes in a calendar month with 99457. So let's say you hit those first 20 minutes on April 15th for Martha. And then between April 16th and April 28th, she has another 20 minutes because there's a lot of things going on with her diabetes. And she's using one of those wirelessly enabled blood glucose specialized meters. So you give her another 20 minutes in the same month of April. Then you build this code, 99458. And on the frequency limits, what I looked up, and this is hard to find, but being a certified endocrinology coder, I know my way around the CMS, different publications and tables and benefit manuals. And the frequency limits, you can build this code 2 times in each calendar month. So that's really good, which means we have an extra 40 minutes actually in that calendar month above and beyond the first 20 initially that we give Martha. Now the consent, yes, we have to get a beneficiary's written signed consent for this is in the statutory language for these RPM services. And we have to have that in the beneficiary's EMR. So scan it in, have her sign it, scan it into your EMR because in an audit, an auditor may ask you to see that. And I created one and I benchmarked it against some other consent forms I found online. But again, I gave it, Gluco was good enough to upload it for you today and you can download it. And if you want to make any changes to it, please feel free. Believe me, it's not copyrighted by myself or Gluco, and you can brand it and do whatever you want with it. Another one of those rules is that the beneficiary, if Martha has not seen Dr. Miller within 1 year, has not been in the office within 1 year, then Dr. Miller is going to have to conduct a face-to-face visit with Martha before he can start the remote monitoring. And then he has to order the remote monitoring, by the way, too. All Medicare benefits have to have an order. Okay, that's just a given for all benefits. So we have to have a face-to-face with the beneficiary from Dr. Miller or a nurse practitioner in the office or a clinical nurse specialist. That can take the form of an annual wellness visit, and E&M, pens up, stands for Evaluation and Management, which is a typical physician or mid-level medical visit, evaluation and management. In transitional care management visit, any one of these would count as that face-to-face visit if Martha has not been in Dr. Miller's office or in the outpatient hospital department where she's getting services for 1 year or more. And of course, Dr. Miller or the outpatient department can bill for that face-to-face visit. That billing is separate and distinct from the remote monitoring codes. Okay, now there are these qualifying visit codes. Again, for Martha's not been in the office or the practice setting for a year or more. There's certain initiating visits that don't qualify as face-to-face, like telephone and online services that Medicare doesn't pay for. So, but they're traditional. The annual wellness visit and evaluation and management visits would qualify. Okay, now, again, the language of reimbursement, some of this language is probably new to you. It's called places of service and entitlement. It's like going to France and having to learn to speak French, right? You don't know how to say coffee in French and a glass of wine in French because, it's all foreign. The language of reimbursement doesn't roll off our tongue real easy unless you're into it, like I am. So a place of service, where is Martha coming? With all the Medicare benefits, ladies and gentlemen, all of them, Medicare will always say these are the approved places of service for the particular benefit. And if it's not on that short list of approved places, then it's not an approved place. That's pretty much it. And so you can see here on the left, we have hospital outpatient, clinic, physician practice, federally qualified health clinic, rural health clinic, home health, and a community residence. And the beneficiary can be at home for this. Now, entitlement, that's from the beneficiary perspective. The Martha has to have Part B insurance. And you say, well, don't all Medicare bennies have Part B? Not necessarily. About 90% of them, when they turn 65, they will opt into Part B, and it is an opt-in. That's where your outpatient benefits are housed. About 90% of them will say, I want to have Part B. But about 10% of them decline that. And if you do opt into it, and that's your choice, you do pay a monthly premium. You do pay an extra monthly premium to get that Part B insurance. So it's always a good idea to check with your beneficiary, ask to see her Medicare enrollment card in her wallet or his wallet to see if Part B is listed on that card. So when you're submitting a claim, your place of service is submitting a claim, and you're like, what place of service code do I put on the claim? The place, say you're doing it in the patient's home. So you're saying, well, is there a code for patient's home? The statutory language says that we use the place of service code where the billing provider maintains his or her practice. The practice where the billing provider does all of his or her medical services. So if you're going in a community residence or the beneficiary's home, but Dr. Miller maintains his office on Harlem Avenue in Palos Heights, Illinois, the place of service would be the practice on Harlem Avenue in Palos Heights, Illinois, not the beneficiary's home. Now remember the two biggest rules of thumb for health insurance billing. And I dropped in these slides, ladies and gentlemen, not to, believe me, I have so much respect for all of you on the phone. Oh gosh, I wish we were live in person. I wouldn't be giving you a hug because of the virus, but I'd be giving you high fives for all the great work you're doing. But I get questions a lot about a lot of Medicare benefits about billing. And the one question I got a couple days ago, I was kind of surprised. This person said to me, well, Mary Ann, for the obesity benefit, if a doctor orders the Medicare obesity benefit, then just because he ordered it, he can bill for it, right? And I'm like, no, just because, if he ordered it, that doesn't mean he incurred any expense to deliver it. I mean, it has to be delivered by one of his employees, and that's he incurred an expense, and that gives him the right to bill. So, and that's actually on it's not really on this slide, but I'm addressing this. The billing provider has to incur an expense in order to bill. I know that doesn't say this on this slide, but this is really important. So just because a billing provider orders the benefit, but no expense has been incurred because his clinical employed staff has furnished nothing. All he's done is order it. That doesn't mean he can bill for it. An expense has to be incurred. The other rule of thumb is you have to choose the procedure code that's the closest clinical match to the service furnished. So if you start your beneficiary on CGM and you're really doing CGM with the Dexcom 6, and again, I'm not promoting a brand name for any financial incentive here, but you put them on the Dexcom specifically for CGM, that's then what you're billing. You're billing CGM codes because that's the closest clinical match. The other thing to bear in mind is you cannot double count. You cannot double count time. So if Martha's getting chronic care management and at the same time, same month, you're doing remote monitoring, and you want to count 3 minutes of chronic care management, which is time-based, and you want to count those same 3 minutes for remote monitoring code 99457, that same 3 minutes, 10 to 10:03 in the morning, you cannot do that, okay? That's double counting, and they won't allow you to do that, okay? And the same with, again, these different codes. Chronic care management and remote monitoring, billing, again, double counting the same time for 2 different codes. Okay. And that's what this guideline says also right here. Okay. Now it says, do not count any time during a day. This may be one of the questions that comes through. Do not count any time during the day toward remote monitoring 99457. That's that 20 minutes per calendar month. When Dr. Miller bills on the same day an evaluation and management visit or a domiciliary rest home visit with those codes, or a home services visit with the codes listed. So translation, Dr. Miller does an E&M, evaluation and management visit, live in person on April 3rd with Martha. And he spends however much time to bill one of those levels of codes. You cannot then also count that time toward 99457. You know, he spent 20 minutes doing the E&M visit with Martha face to face, and he discussed the RPMs. You say, well, I'm going to count that 20 minutes into 99457. You can't do that. Dr. Miller is going to bill the evaluation and management visit, that live visit with Martha, and the time does not go into 99457. Okay. So again, as I mentioned before, a great way to keep up with the new guidelines that Medicare will, not if, but they will be publishing refined guidelines for these remote monitoring codes. I know they will, because again, their initial round of reimbursement guidelines are not comprehensive. There's been a lot of complaints about that. And the guidelines themselves that have been published, I call it fuzzy wuzzy. They're open to interpretation, especially like these medical devices. Like people are saying, does a Fitbit or an Apple Watch count? We don't know that yet because CMS has not given us specific guidance. Okay, so billing providers, because we had a question about the RD. So you can see here on the left what the first round of guidelines that Medicare has given us. These are the billing providers who can bill for these codes. And you can see here that non-facilities and facilities can also bill. And you're saying, this is all outpatient. Well, gee, Marianne, what does that mean? I'm going to explain that in a couple of minutes between non-facilities and facilities. Rendering providers, who can render the services defined by these codes. The same individuals who can bill and the same individuals who can order. Okay, so billing, rendering, and ordering, that subset is all the same. But in the middle column under rendering, look at auxiliary clinical staff employed by the billing provider. And this was a change in 2020. This is terrific because the initial set of reimbursement rules, ladies and gentlemen, I got goosebumps telling you this one. The initial set of rules said only the billing providers can render these codes. And everyone went literally ballistic. I know that's not a real professional word to say, but I feel I'm one with you and I can talk to you for real. everyone really went nuts about that only doctors and NPs, PAs, and CNSs could furnish. So they changed it with all those complaints. You can change the mind of Medicare. And they said now it's auxiliary clinical staff, but they have to be employed by or under contract with those billing providers. Why? Because the billing provider has to incur an expense in order to bill because they want to get their money back. So here's kind of a funny situation. Say that Dr. Miller, actually, he was my doctor before he retired. And at one point, he had his daughter working in his office. Now, whether his daughter was employed or not, I don't know. So if she was working there free because she wanted to learn about medical services, I don't know. He wasn't paying her. And she was sitting down with me, teaching me how to use my specialized blood glucose meter. If he wasn't paying her, then he cannot bill for that code because he's incurred no expense. So I hope that helps you a little bit. Now, I'm not going to go through a lot of detail about facilities and non-facilities because you're getting this deck after today's webinar, and you can go to your favorite reading room and go through these slides that I'm doing a cursory overview. I just have to tell you a little something funny. My favorite reading room, when I go through decks or my diabetes journals, my favorite reading room has a toilet in it. So I'm going to let you picture that, okay? And that's where I love to do my reading. It may be your family room, your bedroom, your living room, but then you can read through these slides. Facilities are what you would imagine, larger places of service, hospitals particularly, skilled nursing, FAQs, RHCs, that kind of thing. And then non-facilities, pharmacies, Dr. Miller's office, walk-in clinics, urgent care facilities. The thing about facilities and non-facilities, Medicare gives them a place of service code, and you can look those up. Like an office, like Dr. Miller's office, the place of service is code 11. A pharmacy is 01. And so those place of service codes have to be inputted on the professional 1500 claim form. So Medicare knows what place of service the service was rendered in. But facilities like a hospital, they use a completely different type of claim form. They use a UB04. So when Medicare gets a UB04 claim, they know it's from a facility, hospital, critical access hospital. And so they don't have to use a place of service code because the claim form, that UB04, is specifically for hospitals. So with that said, all these other things explain that, okay? One more thing I want to say, and then we're going to look at the reimbursement rates. FQHCs and RHCs, okay, those are considered facilities, even though they're clinics. All the other independent clinics are considered non-facilities, but Medicare, I said it before, sometimes their rules are a little bit crazy and outside of what we normally think. So even though FQHCs are, quote, clinics and RHCs are clinics, they're designated as facilities in the Medicare world. Go figure, right? Anyway, what's my point? In the statutory language right now that we have from CMS, FQHCs and RHCs cannot bill separately for the RPM codes. But wait a minute, it doesn't mean what you think. FQHCs and RHCs will still get money from Medicare for rendering these RPM codes. They will still get money. What this means is they're not going to get a separate, distinct payment from Medicare, the way Dr. Miller's office will. And why is that? Because RHCs get paid with a bundled, all-inclusive rate for all services furnished to the Benny on one day. And FQHCs get paid a bundled rate for all services to Martha on the same day under a different type of bundled payment system called the prospective payment system. So you will get paid for RPM in FQHCs and RHCs through these bundled reimbursement methodologies, but you won't get paid separately with the reimbursement rate for each separate code that I'm going to show you now. And that's going to be, we're going to wrap up the webinar then. Okay, so what I did, I clipped this out with my snipping tool, and these are the rates for 2020, and for all of these 4 codes. And you can see on the right, it's non-facility and facility. Now, facility, for most of you on the phone, is going to be hospital outpatient department, critical access hospital outpatient, skilled nursing facility. Non-facility is going to be a physician's office, an independent clinic. That's going to be non-facility. So code 99453. Now, these rates you see on the right are unadjusted. They're not adjusted geographically. These are the national payment rates that are unadjusted for geography. 99454, okay, remember that code, 99454? That is for the setup and the education. And here's your non-facility and facility price, the rates you're going to, again, this is national rates. 99457 for that 20-minute threshold in a calendar month. You see the rates on the far bottom right, and they're different between hospitals and everyone else. And then your extra 20 minutes above and beyond the first 20 minutes, 99458. We have different reimbursement rates between facility and non-facility. So you can see here that non-facility, the rates are always higher if they do separate the rates. Because in a facility, there's more departments to spread over the expense. So the rates are always going to be a little lower. So why move on RPM? Some of you who know me, I'm the queen of acronyms. On 2 of my remote monitoring progress note forms, different formats that I sent you today, I have some acronyms in there. I have an RPM care plan, which is an acronym. So why move on RPM? More reimbursement for you. Modernize your practice to meet your patients' expectations for virtual care, right? Maximize patient engagement in their own care without overburdening your care teams. Get them more involved in their own care because they're doing this in their own home, collecting and transmitting their data, and you're calling them in the comfort of their own home or emailing them on their tablet. Outcomes improvement. The more care you give them virtually, the better their outcomes are going to be, particularly in diabetes and cardiovascular disorders. And RPM validates that the patients expect more personalized and convenient services as consumers. It validates that you're aware of what they want and need, and you're catering to them. It looks great. And for clinical people on this call that you're going to be rendering these services, jump in and do this, promote this, RDs, RNs, pharmacists, because it's going to expand your clinical staff roles and responsibilities. So if you're working in a physician's office, you're working in an independent clinic, an FQHC, an RHC, hospital outpatient department, and you're doing a very limited amount of services because you're an RD and you're doing MNT and DSMT and CGM, and that's it. Getting into remote monitoring is really going to expand your clinical staff roles and responsibilities. You will be more valuable, and then you know what? This is what I would do. I would ask for a raise. That's what I would do. Anyway, okay, so again, please check out my 2 different types of RPM records and progress notes. Feel free to remove my name, modify however you want. If you do modify and make it like you think better, I would love to get a copy. If you want to send it to me, my email address is on the 2nd slide, or 3rd slide in this deck. I would love to see what you've done with them. It would be a lot of fun. Here's just a little snippet of what they look like, but you're going to have the actual Word docs. So with that said, again, I want to thank Gluco and Ryan. We've done a lot of commiserating this last month. He's been wonderful.
Thank you, Marianne, and thank you all for joining us today for our 2nd webinar in Gluco's 4-part Diabetes Connected Care webinar series. Thank you all and have a great day.
Thank you, everybody. It was my pleasure. Hope to talk to you soon. Hope to see